COIN, Community-Oriented Integration Network, is a network of friends, people of experience, who explore how to develop local communities for health, compassionate communities. The main thing today is to hear from Charlotte, who's going to talk about social prescribing and the links with COIN. Before we do that, we're going to discuss what we're up to with the next stage of COIN, because a lot is happening, and we want the more people who understand what we're trying to do and how we're doing it, the better.
Hello everybody, hope you can hear me and see me okay. I'm Charlotte Osborne-Ford. I'm the Chief Executive at the National Academy for Social Prescribing, and I've been very kindly invited to say a few words about social prescribing's development in England and the work of the National Academy. Thank you.
Margaret Hannah. I'm a former Director of Public Health in a health board in Scotland. I'm now Director of Health Programmes for the International Futures Forum, and enabling and supporting people from across the UK in particular, but also further afield, to navigate this system transition in the health and care field, so that we come out of this turbulent times in a rather better shape than we've entered into them.
My name's Pip. I am founder and setting up a domiciliary care company, which is inspired by the Buurtzorg model of care. So the idea that it's small community teams with a flat structure, providing very person-centered care to people in their homes and joining up with communities and social prescribers.
I'm Helen Northall, PCC, which is Primary Care Commissioning Community Interest Company, but that's what we call ourselves, PCC, because it's a bit of a mouthful. We are an organisation that's been in existence since 2009, and we deliver quite a lot of social value, including allowing a platform for health and social care to network, NHS networks. Our day job is to promote and support primary care to thrive and develop. We also have an event management arm, and we do quite a lot of leadership, personal and team development work, facilitation, etc. as well, working across all of England. We did tip our toes into Scotland for a while, but we're now mainly England, Wales, occasionally Channel Islands, Isle of Man, those sorts of areas. So quite a wide breadth, and we do some bits of consultancy across the NHS and wider public sector as well.
Well, I'm David Morris. Good evening, everybody. I am Professor Emeritus at the University of Central Lancashire, and my interest has always been in communities, mental health and social inclusion, and I've operated on that sort of canvas across working in health, the health service, social care originally, the civil service, and with the social exclusion unit, if anybody remembers them. So I've been involved in COIN for, I think, since the beginning.
Yeah.
Yeah.
Long time anyway.
Long time.
I don't quite know when the beginning is, do we? It's just always a sort of
we don't.
A month.
I remember thinking it was a good name though, so I think it must have been very near the beginning. Yeah, so that's me. Thank you.
I'm John Klimo. I am a director of a care association and do various bits of consultancy around the health and social care and sort of voluntary sector space. And in a previous life, I ran quite a lot of social prescribing services. So I'll be pertinent to this conversation.
Hello, Tony Birch, a one-time GP with a special interest in older people, integrated care. I am now chair of Age UK London, which campaigns for a better life for older Londoners, and I'm heading up a campaign for an age-friendly Brent, which is where I live.
Lucy Cope, I'm the COIN administrator. I've been with the COIN, I don't know, I think it's about 8 years. So I've joined it when it was still London Journal of Primary Care, and then things moved moved forward. And yeah, I've been there ever since, and I'm the main person behind the communication with everybody.
I'm Steve Innes. I'm a retired GP from Northwest London and an academic who works still at University College London on primary care stuff. But what's really bugging me at the moment is I can't switch the video on.
Steve, of course, was one of the great movers and shakers in radical general practice in the 1970s and 80s, always in the forefront. In fact, I believe the Prime Minister even came and opened your health centre, which they used to call the health factory or something?
Health factory, that's right.
Yeah.
Yes, he did. Yes, he was very, very interested in it. Went and played with all the machines.
This is Tony Blair. Yes, and it's a lovely practice. Always been at the front of everything. But there.
Hi everybody. I'm Peter Whitehouse. I'm part of the network of COIN in the United States. I'm a geriatric neurologist, but because of my interest in geriatrics, I really am, at least in our system, somebody who really appreciates primary care. I've been involved in community care in a variety of different ways. And one of my particular interests is in how schools fit into that. My wife and I started public intergenerational schools, so I'm interested in engagement of community. And one last comment I have to mention every time I talk about myself, I'm very much interested and concerned about climate and health. So when people talk about community, I want to make sure they talk about the natural community in which human communities are embedded and are part of it. I've been an advocate of social prescribing, which is not terribly well developed over this side of the pond.
So we would like to today introduce you all, and I think some of you already joined our little COIN network in a new platform. And great thanks to Helen, who's with us on the call, for enabling us with that. We now have our presence on NHS networks and the COIN Community Oriented Integrated Network. So that's one of the networks you can find once you sign up with NHS networks. That approval comes from the main team at PCC, and then you can actually find relevant networks. So once you're signed up, you can find us, and that will be a really quick step for us to accept you within our, at the moment, private space. But we'll see how that goes in the next few months. We are still in the early stage. This platform will enable us to share more widely useful documents, resources, all of our videos that we've produced from the past meetings, also promote our meetings that we can do through various functions that we have on a portal. There will be very useful feeds of newsletters posted on a sort of main interface when you log into your account, when you finally have it. And helpful team at PCC, Maria, who's in the marketing and comms team there, has been doing that fantastically for us ever since we're in existence. So few things already are there for those first joiners to view and observe. And we hope that through this platform, we enable further discussions after the meetings, because so far what happens, we see each other every month. Obviously, they're very fruitful discussions, but I don't think they sort of continue on the wider, with wider numbers of individuals that join the meeting. So we hope this will be enabled through this network. So I guess for us today was just to showcase a few of the pages we have in here, information that is in there, and basically encourage people to sign up. And we will be sending further information via email as well, with guidance how to do that. But we hope to move most of our resources and videos into this portal.
Now, through the Journal of Holistic Healthcare, we will publish 2,000-ish word essays about different aspects of community-oriented integrated practice. which are effectively chapters in a book, a virtual book. So the 2,000 word papers will have a lot of the relevant academic references. They will be linked to a 5 to 10 minute video, which we'll have on our, probably, well, we will be somewhere. As well as a 700 or 800 or 900 word blog, which will be on PCC, so that between all these places, we are teasing out how to make community-oriented integrated practice work. And Helen from PCC will be sending out one of these blogs each month, so we gently introduce people into the how-to. So Helen, how am I doing there? Did that sound what you expect?
Brilliant. Well done, Paul. And thank you, Lucy, for showing the screen. You've grasped networks, and I know you're an administrator as well now for the site, which is very helpful because Maria's on holiday for 3 days. So anyone who needs to join, I'm sure you can do the approvals in her absence. So it's really, really good that you're supporting that, Lucy. The whole intention is networks, signposts. It is a free resource for anyone in the NHS to use. And we've got all sorts of weird and wonderful networks on there, including the NHS Cycling Network, which is actually a really vibrant one. But there's many on there that are both very serious in nature, and then for lighter-hearted ones. So we do have around 40,000 active members on NHS networks who get the newsletter each week. And as Paul said, we will be featuring one of the COIN blogs once a month in that newsletter, but also pushing it out through PCC's other publications, which go to integrated care boards, PCNs, practices, and anyone else who wishes to sign up. So it's just getting a wider audience. And I think from some of the initial communications we've done, sending out the first blog, there has been quite a lot of interest starting to come back, which is really positive. But we're really happy to promote the work that you're doing. David Colantomi introduced me, as you know, he's our chairman, to COIN, and one of the areas that we would like to work in more is working with communities. We do it, we have facilitated work between commissioners and providers and communities, and it just seems to fit really well for us to promote what you're doing, because we don't want to reinvent the wheel. Basically, we don't have time and we don't have the knowledge to do so. So we would much rather work with you and promote the work that you're doing through any means that we can. The only publication I haven't mentioned is PCC Insight, which is a more in-depth read. That goes out every 2 months, and we will also be putting a blog in each edition of that as well. So again, it will start to build the story of COIN and get that to a broader audience as well.
This is all so barn door obvious to everyone who's in the COIN network, but it doesn't seem to be so obvious to the rest of the world, that actually relationships matter and they get co-created rather than given. Yeah. And that, you know, you don't get people liking each other just by putting them in the same room. And there's a science to this. There's a way of making things work that works, and we call that community-oriented integrated practice. So we want to drip feed the world with these ideas rather than try and overwhelm them, which is probably what I've been guilty of in the past.
So I'm Charlotte. I'm the Chief Exec at the National Academy for Social Prescribing. And I'm going to go through a series of slides. I'll send them over to Paul and colleagues so that you've got a copy afterwards. Really just to give you an overview of national developments, particularly in England for social prescribing, with a focus on latest developments in research and evidence, and also social prescribing in the 10-year plan and upcoming policy, and then to finish with a few challenges and think about how we can continue to make sure that social prescribing remains high profile and accessible. So a little bit about the National Academy. If you haven't heard of us before, we are a charity, but we are currently funded by government. We were founded by the NHS and by government and others back in 2020 when social prescribing became NHS policy. And our focus is to scale social prescribing, focused on the study and practice of social prescribing, particularly to address health inequalities. And we have 5 core functions. So the first is helping the system better connect up. So recognizing that lots of amazing social prescribing initiatives are happening in isolation, in local patches, and to really ensure that there's consistency and that local community organisations can connect into the health service as best as possible. And we do that a lot through training and education. So particularly training and supporting social prescribing link workers, but also wider NHS teams and community organisations. We have a particular focus on innovation. Almost everything that happens in the social prescribing world is quite innovative because, as you said, Paul, some of this should be obvious, but it still isn't. And there's so much going on sort of hidden in pockets. We run an innovation network. It's got about 900 members, mostly people running really interesting and diverse different projects, everything from nature-based and climate interventions for health, to sport, physical activity, Nordic-walking, cycling, all the way over to arts and culture, opera, everything that you can imagine, really. Our next priority is increasing investment into social prescribing generally, but particularly into community organisations and voluntary organisations that really social prescribing relies on. And then the evidence, so understanding what evidence is available, identifying gaps, highlighting the evidence, and strategically leading to encourage more high quality research for social prescribing. And then lastly, raising awareness. So at the moment, particularly raising awareness with the public and raising awareness with clinicians, because there's still many clinicians, particularly outside primary care, who don't really know what social prescribing is, or they have a sort of they think it's one thing, which it really isn't. So that's why my next slide always says, what is social prescribing? And actually, it's been around for decades. Many of you will know Sir Sam Everington and Bromley by Bow, but actually there was only a formal academic and agreed definition determined in 2 years ago in 2023. And this is a global definition. It was done through a Delphi study with different practitioners, researchers and leaders, about 40 of them across about 20 countries. And so this is now the official recognised definition. And what's really interesting is we see here that social prescribing is a process. It doesn't just mean doing something for your health in the community. It means a trusted individual, so typically a GP, but certainly not always a GP. Could be someone in a community setting, a nurse at a school, recognising that somebody has non-medical health-related social needs. So there's this sort of identifying of a problem in somebody that somebody who's being supported. And then this process of co-producing, we've already heard that phrase, a social prescription. So typically what that means is asking what matters to you, what's important to you, what do you enjoy, what are your goals, and then together identifying what's available in their community, in their neighbourhood. It might even be statutory services that can help them with this goal of being improved health and well-being and stronger community connections. And there is no typical social prescription. It is incredibly varied. I've worked in the charity sector for at least 20 years, and I still come across such amazing, unique and distinct charity and community groups, even in my local area. So we know there's over 168,000 charities, but there will be many more unregistered charities and community groups that are out there. And every neighbourhood, even deprived neighbourhoods, will have amazing things going on. And what social prescribing tries to do is understand what's available, to map it, to research it based on what the needs of the person or patient is. So social prescribing's made huge progress in England. In fact, many countries around the world look to England as the model, even though we've got many flaws in our model. So it became part of the NHS GP contract in 2019 as part of the last long-term plan for the NHS, and particularly the strategy for personalised care, which was called Universal Personalised Care. It sets out various initiatives to make the NHS more personalised. And it said, as part of that plan, that there would be increased funding for GPs to draw down to pay 100% of the employment costs of a social prescribing link worker. And with that, we have guidance, role descriptions, a model, a workforce development framework, setting out what that means in practice, what these new roles do, how they should be managed and supported. Since then, we now have around 3,300 link workers employed in GP practices. And critically, the GP contract says you must provide a social prescribing service. It doesn't say what it must do. It doesn't say how big it should be or how many patients should access it, but it's a universal offer within primary care. And our data suggests probably about as many, again, link workers, so about 3,000 employed in other parts of the NHS, typically funded by local authorities or local health trusts. Some really fascinating data has come out of UCL, which I'll talk about a bit later, that shows that there were 9.4 million consultations in primary care that involved social prescribing or connection to community assets. And they can do that, they know that research through SNOMED coding, that they can pull off a research database. So it's a big scale of what we're talking about. And our own research shows that around 22% of people in England now recognise and understand the term social prescribing. And that was about 10% 5 years ago. We have very significant media interest in social prescribing because many patients who go through the process feel it's really life-changing. They might have spent a long time trying to access services that haven't worked in that holistic way and been very frustrated, and we find they're often very keen to share their stories. So we encourage that, and we make sure that where possible the media talks about it in an effective way, and really helps people to articulate how it's made a difference, to encourage others that might need it to ask their GPs and to get involved. Critically, we in order for social prescribing to continuously grow, one of the main challenges we have is it good value for money for the NHS? Because the NHS is paying for those social prescribing link workers and sometimes for the interventions. So NASP put together this report a year ago, which looked across 9 different health systems where they had collected data on people that have used social prescribing to see if they typically have less usage of the NHS than otherwise. And what we saw is that in many of the cases, they had some really good data that showed a reduction in GP appointments compared to control groups, reduction in A&E attendance, reduction in unplanned hospital admissions. So whilst this isn't academic research typically, it tends to be sort of service evaluations and business intelligence data from health systems. It gives us a good picture that social prescribing isn't just a nice to have, it's part of a sort of cost-effective health service, and it should be offered by all parts of the health service. And we put together this return on investment tool for NHS commissioners to encourage them to commission both social prescribing programmes and link workers in other parts of the NHS. We had a data analyst reviewed 19 different studies. Some are academic research, some are just evaluations, and draw conclusions from those. You can, the link there will take you through to the page on our website which explains it. And essentially, he looked at what on average does a social prescribing intervention do in terms of reducing NHS demand. And now obviously lots of programs are very different and the research is very different, but what we found across all 19 studies is that on average it delivered £418 in NHS benefit, and most of that benefit comes from avoiding non-elective admissions, as you can imagine. So although the percentage of avoided admissions was relatively small, it was about 5% in some cases, the cost of those admissions are so high that it very easily pays for itself. And other important evidence that's come out recently, this study was sort of 5 years in the making, really. It's funded by the National Institute for Health and Care Research, delivered by Manchester University, and it published in April this year. And it looked at the GP satisfaction survey across England, and it looked for patterns between the number of link workers employed in a GP practice and the scores in patient satisfaction for those practices. And what it found is statistically significant link. The more link workers are employed in an area, the more likely patients are to say that they have confidence in managing their long-term condition, they feel more supported by local services, and they have a more positive experience of general practice. Now, it was a small increment because we're talking about small numbers of patients, but statistically significant. And I think that's a really important demonstration that social prescribing has that system place level impact, even if we're only talking about 2 or 3 link workers in a particular place. The other research which came out just last month is from University College London, and this was published in The Lancet, and it looked at the scale of social prescribing over that 5-year rollout, and it does that through what they call CPRD data, which is GP medical coding data that's available to researchers. And that's how they estimated this figure of 9.4 million consultations over the 5-year period. They only studied up to March 2023, and what they saw was really significant increases over the years. And in 2023, there was an estimated 1.3 million consultations. So it'd be really interesting to see the data for 24 and 25, and we haven't got that yet, but we hope if they can access further funding, they'll be able to run that research. But again, it shows a real demand from patients. This project is a government-funded project about nature-based social prescribing, which came to an end in March this year. This particular piece of research was published on the first wave of the programme. And what this programme did, it had funding from Treasury and other government departments. And then it went. That funding went down to 7 places who embedded nature-based green social prescribing within their mental health services. And then it was evaluated by Sheffield and other universities. And what we saw through this programme, it's a large-scale programme, over 8,000 people with mental health needs, and that it really reached into socioeconomically deprived areas, that people who were referred very typically took up the referral, which they couldn't say about some other mental health interventions, such as CBT. So it had very high acceptability. Very good improvements in self-reported well-being. Some of the pilots looked very specifically at using clinical scales for anxiety and depression, and saw very significant reductions, and that it not only generated income locally, so the funding went down to the local site, it enabled local charities to match fund, typically organisations like local wildlife trusts, nature conservation and other sorts of groups. And that there was at least a return on investment of £1.88 for every £1. So green social prescribing, going back to the earlier point about climate, is being really embraced by Natural England. And they will be releasing their new strategy next week, and they've said there will be a commitment to furthering green social prescribing in their strategy. So I think that's really positive. This is some more data from UCL, who we are at NASP working particularly in partnership with, to share the research and data on social prescribing to encourage greater take-up. This particularly looks at whether social prescribing, who is it reaching, and is it reaching in terms of inequalities? And what we see really interestingly in deprivation is, just as we'd hope, the most deprived areas, so 1, 2 and 3, have the highest percentage of referrals. So this isn't GP medical data, it's data from a social prescribing case management software called Elemental. They have, they're probably the main digital system that social prescribing services use. They have millions and millions of patients on the system, but they gave UCL access to cohorts so they could do this monitoring. And what we see around age is a mixture of ages. Interestingly, really low numbers for age 70 to 79. I don't know why that is, but very typically we see social prescribing reaching working age people, because often it's the only service available for for working age people whose needs are either not really complex yet, or who need help to sort of map and understand what's available. And you'll see the number one reason for referral is around mental health. This is another report that UCL are just about to publish. It's currently at preprint, and it looks at well-being and social prescribing, and again looks at large numbers of patient records, about 20,000 patient records. And not surprisingly, you see improvements in all of the self-reported well-being measures that are used, and they've been able to attach a sort of cost value to that, which again is often what we're challenged on by commissioners and policymakers to demonstrate there is a return on investment. But even if we forget the return on investment there, I think it's very encouraging to see evidence that social prescribing does increase life satisfaction, life worthwhileness, happiness, all the things that we should value, and again, a reduction in anxiety. So great to have a colleague from USA here. Social prescribing is definitely going global. In fact, just last week was the Social Prescribing USA Summit in New Jersey, and one of my colleagues went over. So it's really growing, and although it became health policy in England, and we were the first country to make it universally available, many other countries are catching up. And sometimes that's about sort of framing existing community-based interventions and activities under the banner of social prescribing. And sometimes it's literally country leaders will come to England, see what's happened and the progress, and replicate it. One of those examples is Singapore, but also South Korea, incredibly interested in social prescribing. In fact, they sent a television crew 2 weeks ago to NASP and to interview me, and another one's coming tomorrow from a different television company, which I think is really interesting. South Korea very much a leader of innovation, and we coordinate an international collaborative. We've got about 150 leaders from either health or academic or community partners across about 35 countries. And this report we did last year, published in partnership with the World Health Organization, is a sort of overview of all of that. The NHS 10-year plan, I'm sure you're sick of hearing about it now, but to say, obviously we know that the three main shifts, and social prescribing should be absolutely key, particularly hospital to community and sickness to prevention. But actually, it's not a huge part of the 10-year plan. There's a very strong focus on digital and AI. And so we really have to think about what are the ambitions in there and work backwards from those. And I think there's two really important commitments in the 10-year plan. The first is around scaling neighbourhood health and saying that there will be scaling new roles, so community health and wellbeing workers and other roles like that, and further existing proven models. So by that, we hope they mean social prescribing. But there's also a commitment in there that 95% of people with complex needs will have a care plan, and that they will be co-created and cover holistic needs. Well, that's literally what social prescribing link workers do, that co-production of a plan for health and social needs. Just to flag at the moment, the Department of Health has an open consultation about the future of the workforce for that 10-year plan. We see that as really important because we need government and NHS England to recognise that we need a workforce who can deliver social prescribing. We need more non-clinical health roles like link workers and health and wellbeing coaches and others. So if you are interested in this and you have got time, please do log on and submit a response. So I would say the key challenges from our perspective is this sort of focus on digital and AI as being really the solution, and almost obvious risks around digital exclusion, but equally really not thinking about relationships and everything that is really important in terms of trust, personalization, holistic care, and a worry that some of that will be sidelined with the sort of solution that NHS Digital can do it for you. If you work in the voluntary community sector, you will know that they are under incredible pressure at the moment. We're seeing funding for small groups reducing all the time. And there's never been a strategy for the voluntary and community sector, only ever this investment in link workers, never into the wider community on which they're reliant. And we've done a lot of work trying to really raise the profile of the need for that strategy and investment. So we heard already that social prescribing is in the GP contract, but that funding for link workers is no longer ring-fenced. So That's the Additional Roles Reimbursement Fund. It started off back in 2019. Social prescribing was the only role that was 100% funded. Now the fund is probably 20 times bigger, and you can use it for GPs, nurses, dietitians. So there's a risk that some GP practices are investing in more clinical roles. And we know that all while this is happening, inequalities are increasing, demand from patients is increasing. So we really need to see a national strategy for social prescribing, because it isn't just about link workers in GP practices, it's about the whole NHS, but it's also about other public services recognising social needs of people with health problems. And so we spend a lot of time influencing MPs and ministers and sharing the evidence to really raise the profile. If you want to help, one of the easiest ways you can do that is to sign up to become a social prescribing champion. Essentially, you will join a network at NASP of other champions and be sent all of the latest updates, evidence. You get a lanyard, you get a booklet, and you can champion social prescribing in your practice or leadership role. And it's particularly focused on people working in health, NHS workers, but not only. So do check that out if you'd like to sort of continue being working on social prescribing. And that is it. Or if you'd like more information, obviously we have our website and you can follow us on social media. But I will stop sharing and then we can have a discussion.
Yeah, thank you, Charlotte, very much for that presentation. I wanted to just ask a question. You tackled it in the challenges a little bit in the challenges slide, but I mean, how do you see the role of social prescribing in terms of building the community capacity that people depend upon to make a success of the social prescriptions that they are given? There's a lot about mapping, there's a lot about understanding what's out there, but there's also a very significant recognition about the plight of the voluntary sector. But it's not just organised voluntary sector, it's community networks of many sorts that must be stimulated in some way by the advent of social prescribing and its effectiveness. But what I want to know is how is that being operationalized and known about and researched and represented in social prescribing narratives?
You mentioned commissioners and the fact that they were influenced by the economic arguments. I think you'll find in trying to convince other people as well, other stakeholders, the monetary figures that you quoted will have great traction. And if I could...
These people here, Charlotte, those two areas, I mean, you could say that social prescribing has been focused on individuals and their social needs. What about its ability to develop communities? And the other is how to persuade people of the cost effectiveness when there isn't any mechanism to transfer the cost savings in hospitals to pay for this that's doing it in the community. Over to you.
The first question about sort of community development, it's a real flaw in the model. And I think it's so interesting when we do go to other countries and talk about what good social prescribing looks like and how it should evolve. We always get the same question is, that's great, you've funded link workers. What about the community? And a sort of shock and horror that there was never a strategy, let alone funding for that area of work or infrastructure. So, for example, in Canada, they have decided from the outset that they will have equal attention, strategy and investment into the health sector with link workers and connectors, and into the community sector with community development, with all of those sorts of things. And that is obviously a better model, but we didn't have that model in England. The guidance for social prescribing link workers really says that they should spend some of their time supporting individuals, supporting patients in GP practices, but they should also spend their time in the community, setting up groups, doing outreach, going to food banks, meeting patients, strengthening communities. What's happened in reality is incredibly high demand from patients with really complex needs. There aren't the number of link workers they should be, and so it's that side of their role that gets forgotten. So NHS England would say, well, it was always part of their role to do that community development, and they should be doing that community development, but the reality is they're not. Certainly at NASP, we've done what we can to identify that, and we produced a report last year on community-based social prescribing, which you can take a look at on our website. And there are obviously lots of other partners that work to strengthen communities, but they are equally at risk of lack of funding, lack of resource. And I think many of us thought with a Labour government coming in, we'd see increased investment into community development and communities and neighborhood health. We haven't seen that yet. So I think it's a critical point, and we're you know, I was in Denmark last week talking about social prescribing, and they're all saying it's amazing what you have in England. I was saying, like, hold on, it's not
Grass
perfect.
is always greener, yeah.
Yeah, exactly. And the second point about the economics, yeah, it is challenging. And of course, even if you have reduced demand, that's not sort of cashable savings. All it does is enable slightly more sort of capacity, but for a never-ending torrent of need. And so, yeah, it's difficult to argue, but at least we're able, with some examples, to show there is reduced demand, because we hear about it anecdotally. We know logically it should happen, and it's taken a long time even to get some data that shows that there is a reduced demand. And you know, the truth is that there hasn't been large scale investment in social prescribing outside of primary care, and maybe the data just isn't sufficient enough to do that. But perhaps, you know, commissioners say to me, even if I see that there is reduced demand and cost savings and income generated, I still have to decommission something else to invest in this, because my budget isn't increasing. So what do I decommission? And I think that's the reality of where we are at the moment. But it's certainly a lot of progress in the last few years with having some credible numbers.
We would love to work with you on that strategy, Charlotte. I've said many times that, you know, when my wife was dying at home, she had not one night outside of the home in the last 10 months of her life, which must have saved tens of thousands of pounds. Actually, it cost the NHS more because there was no facility to transfer the money we saved the hospitals into the extra cost of district nurses, palliative care nurses, and so on. Until that is recognised, all it will do is increase costs.
So my question is, have you seen a shift in the profile of how link workers are being used to support people in primary care? Because one of the things that was happening very much when I was running social prescribing services, we started out with a relatively pure social prescribing model. It was a little bit more value-added intervention based. The link workers could deliver an information advice and guidance product or a health coaching product, as well as the sort of classic social prescribing prescription element as a way of kind of adding value. And obviously there was an element of sort of primary care demand management within it, but acceptable in the sense that the right people were coming through the service with some sort of health element, but an underlying kind of social need. And more we started to see a push for clients that basically was about long-term health condition management. More and more kind of focus on, you know, essentially, I'm a GP, take these people who irritate me off my caseload. And I wonder if that has continued, and to what extent that's affecting the kind of the overall model. The point I was going to make is we saw exactly the same thing with this challenge of, you know, how do you support and fund the community activity alongside? I'm quite cynical about people listening to numbers and more about how you win the political argument. And I think the only argument we got traction with was talking with primary care colleagues about, you know, as a GP, how effective would you be if you couldn't buy any drugs? And that sort of started to kind of get, oh, I get in my world how this works, because otherwise it was, you know, why should an NHS provider give money to the flaky community providers? You know, that kind of element of it came back a lot. But even so, it was incredibly kind of tough, and also there was an acknowledged impact on destabilizing community activity as a result of the shift of additional demand into it.
So your question about sort of link workers, I think what we've seen really is a diversifying of how link workers are used. So in some areas, they're used in the way that you described originally, sort of some sort of extra skills, but really responding to GP referrals. In some, they're very focused on proactive social prescribing, which means they get a list pulled off and they go and support them. We've heard some, I was going to say horror stories, we call them horror stories, where link workers are given only 15 minutes per patient and they see them once, which isn't social prescribing at all. It's basically signposting or reception type work. And of course, then they say, well, there's no outcomes. Well, there won't be if you don't let the person sort of have that time. The neighbourhood health implementation work that's going on at the moment from NHS England Department of Health has a particular focus on exactly as you describe, long-term condition patients. So they call them long-term conditions, not complex, rising risk. So I think it's people that are where they want to sort of catch them relatively early, but they've got a number of conditions. They're probably in the most deprived areas. And the whole of the neighbourhood health model, not just social prescribing, will be focusing on that cohort of the 5%. So I think we'll certainly see social prescribing become almost reduced down to that mechanistic function of meeting the particular strategic needs that NHS England sets for an area, at least in the short term. And I think a lot of what we're trying to do at NASP is to raise the profile of what you can do with that funding as a GP practice to do other interesting and diverse things. And we've seen everything from link workers focused on obesity, child health, mental health, and some really interesting models, frailty, to